excellent topic that's going to be presented by Dr. Al-Fadl Shaybani. And the topic is about Yescarta in real-world evidence. Dr. Al-Fadl, he is a consultant hematologist at King Faisal Specialist Hospital and Research Center in Riyadh. He has a special interest in treating lymphoma, and he has a dedicated clinic for lymphoma and CAR T therapy. Before we start, I would like to thank SSBMT for organizing this webinar and the sponsor of this webinar, Gilead Kite. Kindly, you are requested to post your questions in Q&A and A box or in the chat, and we will answer them. Now we will proceed with the lecture. Dr. Fadl, you can start.
طيب. السلام عليكم ورحمة الله وبركاته. Can you see my slides?
Yes, we see it.
طيب. السلام عليكم ورحمة الله. Thanks for the invite for today. So today what I will be sharing is basically Yescarta real-world evidence. What I try to do here is basically to give the real evidence, what put Yescarta in the map for treatment of diffuse large B-cell lymphoma, and then I will share some real-world evidence. I try to put it in a way that I make it a little bit more interactive. So this is my disclosure. So if we look to basically the paradigm prior to the CAR T-cell therapies, which wasn't far away, by the way, it was like 4 or 5 years ago. 4 or 5 years ago, what we used to treat everyone with chemotherapies. So let's say if you have 300 patients, with R-sharp therapy, you'll probably be able to clear around 60% of patients. So 60% of patients will have sort of a long-lasting remission, or what we call it cure, of diffuse large B-cell lymphoma. 30% of patients will have relapse of the disease, and 10% will have a primary refractory disease. And this is where basically the trouble is. So if you're taking around 300 patients, 200 patients will be cured with R-sharp therapy. 100 patients will have sort of either relapse or primary refractory disease. Off the bat, if you look to everyone, 50%, probably 50% of patients will be eligible for a transplant, and 50% of patients will not be eligible to transplant. And those who are not eligible to transplant, it's sort of a death sentence, because at that time we did not have a lot of targeted therapies for a treatment of lymphomas, unfortunately. But right now we do have. Among patients who are transplant eligible, even with salvage therapies and with autologous stem cell transplant, out of 50, only 10 patients will have a long-lasting cure. 40 patients will have a relapse disease. So if you put it in a context, 300 patients, 200 patients will be cured. Out of the other 100 patients who will relapse or have sort of a relapse refractory, or 40% of your patients' population, with chemotherapy alone, only 10% of those will have a long-lasting remission with chemotherapies. 90% of those patients will die. This is prior to CAR T therapies and targeted and bispecific therapies. However, not all relapses are the same. So this is Orchard trial that looked into basically different salvage therapies in a second-line setting, which is basically not the focus here for today's talk. But I would like to highlight that not all relapses are treated equally. So patients who have either a primary refractory disease or relapse within 12 months, those patients have an extremely poor survival. Median overall survival, as you can see here, is measured in months, is less than 1 year. Median overall survival is 10 months. For patients who relapse, less than 12 months of R-sharp therapies. Patients who relapse after 12 months of therapies, or what we call it chemosensitive disease, they fare a little bit better with chemotherapies. So prior to the CAR T-cell therapies, we really did not have a lot of options to treat those patients who relapses within 12 months. And we know for a fact that those patients usually are chemo-resistant disease. And this is what basically put CAR T-cell therapy in the map. So if we look here to the Zuma 7 trial, there was, of course, Zuma 1 trial, which looked into a third line setting, which I'm not going to bother you with now. But Zuma 7 trial looked into using CAR T cell therapy as a second line setting for a treatment of a primary refractory diffuse large B-cell lymphomas. So this is basically what axicell looks like. So we've had a single chain variable fragment, which basically targets, which is the chimeric part of the CAR T cell therapy, targets CD19. You have the hinge, which basically gives sort of a mobilities for the single chain variable fragment, and we have the co-stimulatory domain. And the co-stimulatory domain in a setting of axicell therapy is CD28. This trial looked into the usage of axicell therapy in a second line setting in a high risk population compared to the standard of care at that time, which was salvage therapies. So this is the trial. Eligibility, age above 80, large B-cell lymphomas. The patient should either be a primary refractory disease patients or patients who relapsed less than 1 year. And patients were randomized to either receive CAR T cell therapies or to receive salvage therapies and autologous stem cell transplant. Those who did respond went on for a treatment, and non-responder were taken off the protocol. And if you can see here, basically, the overall survival was a key secondary endpoint for the treatment in this trial. So if you look here, it was very well balanced between the two treatment arms when it comes to the median age, disease, response to therapy, prognostic factor. But I would like to highlight here basically the fact that primary refractory disease was a significant bulk of those population. 70% of those patients were a primary refractory disease. This is a very, very important to know and to notice this, because those patients usually are chemo responsive disease. Another important, which we will discuss, is basically elderly, accounted for around third of patients. So if nearly three times patient received axicell therapy to compare to the standard of care salvage therapies. However, a very important note that even with the standard of care, patients who receive salvage therapies, autologous stem cell transplant, if they relapse, they are fit to receive CAR T cell therapy. So the real question at the time of this trial, it has been proven that CAR T cell therapy works in a third line setting. But the key question was, you know what? CAR T cell therapy is an expensive therapy. Should we just delay it until the third line of therapy and we give salvage therapy? If it works, works. If it doesn't work, we can salvage patients with CAR T cell therapy. Or actually giving it in a second line setting specifically has its own value. So the primary analysis, of course, showed a lower hazard ratio in patients who receive axicell therapy compared to the standard of care. And the primary overall survival, which was the main the driver and the main outcome that everyone was looking for, was basically significant with axicell therapy compared to the standard of arm. So with a median follow-up of 47% of 47 months, around 46% of patients were alive at 4 years who received salvage therapy compared to 54%. And that was statistically significant. And this basically puts axicell therapy in the map for a treatment. What does this translate to when it comes to the lowering the risk of death because of axicell? This lowers it by close to a third, 27% relative risk reduction with axicell therapy. This is despite that nearly half of patients who receive salvage therapy eventually received CAR T cell off protocol, of course. So this answers, this trial tells us that actually giving CAR T cell earlier in the treatment of diffuse large B-cell lymphoma improves the outcome rather than delaying it. Why is that? Because you're dealing with a fresh T cells therapies that you can basically take it into the lab and do CAR T cell therapy out of, rather than beating the patient's own T cells with multiple chemotherapies. So the benefit was seen across several pre-specified group. And as you can see here, of course, the progression-free survival was superior for patients who received axis cell therapy to compare to the salvage therapies. So this is a key point that we need to keep in mind, that SRS, risk of SRS of any grade around 92%, patients with axis cell therapy, grade more than grade 3 is around 6%, with neurological events more than grade 3 around 21%. So this basically changed the ball game for a treatment of diffuse large B-cell lymphoma. Diffuse large B-cell lymphomas in a primary refractory or less than 12 months, axis cell therapy improves the overall survival. So this brings us the question, what about elderly patients? You know, when you're dealing with patients who are young patients, it's a no-brainer. Primary refractory, I'm going to take him for CAR T cell therapies. But what about patients 65, 67, 70 years of age? Can you take them to a CAR T cell therapy or not? And this is an abstract that looked into those specific patients within Zuma 7 trial. And they looked into patients aged more than 65 and patients more than 70 who received axis cell therapy, and they analyzed it based on a multivariate analysis. As you can see here, it was fairly well balanced between the two treatment arms. A primary refractory disease in patients with axis cell therapy was actually higher compared to the standard of care. And again, axis cell therapy proves efficacious even in setting of an elderly individuals, age more than 65 and age more than 70. Axis cell therapy proves to be of a higher value than the standard of care therapy. So this tells us that age is not a contraindication. So this is very different from the way we visualize and we treat patients with chemotherapy. With chemotherapy, we always look into the age as a factor. Even with autologous stem cell transplant, we'll say, you know what, above age of 65, you become anxious. Closing to age of 70, you become very anxious about getting autologous stem cell transplant. When you're dealing with in a CAR T cell era, this equation is a little bit different. We still look at the patient's performance status, but performance status of the patient is the main driver that we decide on whether patients can go for a CAR T cell therapy or not. Progression-free survival again was superior with in patients who received axis cell therapy compared to salvage of care. And another key point that we need to keep an eye on, the risk of neurological events is slightly a little bit higher in patients aged more than 65. As you can see here, grade 3, around 27%. CRS around all patients, probably they will have some sort of any grade of CRS, but more than grade 3, around only 8% of patients. So this tells us that we still can use axis cell therapy in elderly individuals. Then does the tumor, the bulkiness of disease, affect the effect of CAR T cell therapy? In another word, if we're dealing with, we have, like, you can imagine it, you're having two different patients. One patient's very, very minimal disease, still a primary refractory disease. That a patient, you give him R-CHOP therapy, end of treatment, PET scan is showing, still showing some sort of activities. Does the volume of the disease have a huge impact when it comes to axis cell therapy? This is basically an analysis from Zuma 7. If you look, there is a numerically statistically still insignificant. Axis cell therapy likely works better on patients with a lower metabolic volume than patients with a high metabolic volume, but this in the Zuma 7 trial did not reach a statistical significance. However, if you're comparing bulky patients and you take them for an axis cell therapy, or bulky patients, you take them for a standard of care, salvage therapies and autologous stem cell transplant, this is where you can see the difference. Axis cell therapy outperforms standard of care therapy. Then the other question, does the tumor volume affect the duration? So we know that you can give CAR T cell therapy to bulky patients and they respond to therapies. But however, does it affect the duration, the bulkiness of disease? Does it affect the duration of response, meaning lower relapse rate? And this is again, axis cell therapies showed that it does. Patients with a lower baseline metabolic volume, it's high, it's with a low metabolic volume, they do respond higher than patients who have a high metabolic volume. LDH, on the other hand, there is no statistical difference between axis cell therapy if the LDH is high or normal. But however, there is a difference when you compare axis cell therapy to the standard of care salvage therapies. What about quality of life for patients with CAR T cell therapies? When we are analyzing patients for CAR T cell therapies and CAR T cell therapy impact of CAR T cell therapies on patients' quality of life, we can look at it into different perspectives. One perspective is disease related. Of course, if the patient having a bulky disease that is compressing on an organ or just merely having the bulkiness of disease, it's gonna affect the quality of life. CAR T cell therapy is not a walk in the park. It's associated with the physical and emotional burden of disease. And there are treatment-related side effects, mainly hypogammaglobulinemia, which predisposes patients to develop infections, cytopenias as well, which tend to be reversible. But however, the duration of cytopenia can extend and can be life-threatening for patients because of opportunistic infection, and lifelong neurological side effects as well is another consideration. So if we look here, patients in Zuma 7 trial, when they looked into patients who received the standard of care versus axis cell therapy, both of them, day 50, post-therapy, post either autologous stem cell transplant or axis cell therapy, both of them, they reported a decrease in quality of life. However, what is interesting is axis cell therapy, and this is what we see in the clinic actually, they do have a faster rebound to normal limit compared to salvage therapy and autologous stem cell transplant, because with salvage therapy and auto transplant patients, the returning to normal activities may take a longer time interval. So quality of life recovery was faster for patients who receive axis cell therapy compared to the salvage therapies. This is a real world evidence from US. Again, it showed similar findings. Patients who received axis cell therapy, there is a dip at the beginning if you compare to the baseline pre-CAR T cell infusion. Compared to day 30 of CAR T cell therapies, there is a dip when it comes to the quality of life, but patients usually recover. After day 60, patients become better and much better, and they are able to return back to their normal life, provided that the patients are going to receive IVIG therapies, they will be receiving anti-prophylactic therapies, etc., as per the guidelines. So if we look here, the questions deeper into the questions of the quality of life, this is basically the PROMISE 29 score. This is a real world evidence from several single center observational trial in the US, which basically this score, the PROMISE 29 score, looks into the quality of life measures, and the standard is 50. If the patient is above 50, that means the patient is worsening more than the disease match. If it's less than 50, the patient is, as you can see here, physical functioning tends to worsen with therapies. Pain tends to get better with therapies. The most important thing that we need to keep in mind, the anxiety. The anxiety patient become anxious. And this is something that we need to keep in mind when we treat patients with CAR T cell therapy, not to focus only on the physical complaint of the patients, but their psychological well-being is a very essential component. We need to address anxiety, we need to address depression as well for those patients. So at 90-day post-infusion, patients experience a significant increase in physical functioning, however, a lower level of pain. However, the anxiety is still still higher than acute therapy. This is Yescarta, which is a French registry that looked into CAR T cell patients, looked into French patients who receive access therapy in the French population as part of LISA study group. Access cell therapy, of course, proven and has been proven to be superior to the standard chemotherapy in a second-line setting. And access cell therapy has been used in France for this indication since July 2022. So what they did here, they looked into all patients who received CAR T cell therapies between July 2022 and August 2023 in a second-line setting in early access program. As you can see here, the number is around 171 patients evaluated for CAR T cell therapies. What is important to keep in mind that although Axi-cell was requested for 300 patients, only 200 patients were able to be treated with CAR T cell therapy. So a third of patients did not receive CAR T cell therapy, unfortunately. The median time to treatment in France was around 55 days, which, to be honest, I find it a little bit long. Here in Saudi Arabia, we're having around close to 4 weeks to 5 weeks interval. So 55 days from the apheresis or from the tumor board until the infusion is quite a lot. And this has been translated into a number of bridging therapy. Majority of patients received 1 bridging therapies for treatment. However, there are patients who receive 2. There are even patients who received three bridge lines of therapy because of the delay of CAR T cell therapies. And the number of treatment varies between anti-CD20, chemotherapy, and steroid therapy. So this is the patient's characteristic. And this is basically the toxicities. The toxicities, again, CRS of any grade was around 87% of patients having any grade of CRS. However, the significance, grade 3 or more, only around 4% of patients who received axi-cell therapy had this grade. What about neurological toxicities? Around 12% of patients had higher than grade 3 toxicities. So this is similar to what axi-cell with ZUMA-7 have shown. This is the outcome of axi-cell therapies. Complete response rate with axi-cell therapy in a second-line setting was close to 66%, with partial response around 21% of patients. So this is again matches what ZUMA-7 trial have shown. When it comes to the survival, patients who received axi-cell therapy, they did have an improvement in survival compared to patients who did not receive CAR T cell therapies, and the progression-free survival was higher for patients who received CAR T cell therapies. This is another trial that looked into patients who received axi-cell therapy or liso-cell therapy in a second-line setting in United States. As you can see here, the 6th-month overall survival for patients was around 84% of patients. So we're seeing here different real-world evidence that's still cementing and proving that axi-cell does work in a second-line setting. The survival of benefits of ZUMA-7 trial has been constantly replicated in real-world evidence. This is another real-world evidence. Again, the 6 months overall survival was around 91% of patients in patients who received it in a second-line setting. This is a French trial. It was a very interesting trial in which what they did, they looked into patients, they looked into centers within Spain, centers who do have access to CAR T cell therapies, and centers who don't have access to CAR T cell therapy, or they don't do in-house, or they don't do CAR T cell therapies. They just refer patients for CAR T cell therapies, and they looked into the outcome. So if the patient goes to a center that has a treatment center, a center that provides CAR T-cell therapies, their median overall survival was 18 months compared to 8 months of therapy for patients for a referral centers. The author of this basically paper concluded that probably one of the reasons why there is an improvement in overall survival for centers who do have access to CAR T-cell therapy is because early referral. So if the patient is your patient and you see the patient as a primary refractory disease, you can immediately discuss him for a tumor board and order CAR T-cell therapies. Whereas in referral center in Spain, it takes a lot of paperwork, so the referral may be delayed. And this basically just highlights the importance of early referral for patients with who are eligible to receive CAR T-cell therapies. So CAR T-cell therapy, we have proven that it really works in a second-line setting. However, there are a lot of patients who are eligible to receive it in a second-line setting and they don't receive it. Why is that? We would think that probably because patients in a second-line setting are not receiving CAR T-cell therapy because they are ineligible. But in fact, the real evidence shows that those patients actually the ineligibility to CAR T cells account for minority. Only 12% of patients in a second-line setting, they were ineligible to receive CAR T cell therapies. Majority, 75% of patients who did not receive CAR T cell therapies were eligible but never received it for a variety of reasons. Delay in referral, trying salvage therapies, etc. And this just highlights the importance of early referral for patients who are eligible to receive CAR T cell therapies. Does it really differ whether we're using axi-cell therapy or lysocell therapy or T-cell therapy for patients with diffuse large B-cell lymphoma? This is a trial that, this is a retrospective analysis of multi-centers that looked into around 600 patients with relapsed refractory diffuse large B-cell lymphoma. Some of those patients received axi-cell therapy, some of them received lysocell therapy, and some of them received T-cell therapies. And the point of this analysis to see which therapy is better than the other. If we look, it was fairly well balanced between the different treatment arms when it comes to the diffuse large B-cell lymphoma subtypes. The bulkiness of the disease was higher a little bit with axi-cell therapies. Bridging therapy was very well balanced between them. So if we look here, there is an improvement. Lysocell therapy, axi-cell therapy does improve the overall response rate, and they do have a comparable outcome compared to T-cell therapies. So in a subgroup, the responses was seen equally between axi-cell therapy and lysocell therapies. So the survival as well is equal between lysocell therapy and axi-cell therapy. The 2 years progression-free survival for patients who received axi-cell therapy was 46%. For patients who received lysocell therapy was around 45%. This translated into a 2 years overall survival. Axi-cell therapy around 63%, lysocell therapy around 58%. So there is really no difference when it comes to the progression-free survival or overall survival if you compare axi-cell therapy to lysocell therapy. So if we look here basically to the response rate, again, as I mentioned, the CR rate was very well balanced between the two treatment arms. And it wasn't really statistically significant between axi-cell therapy and lysocell therapy. And this is the survival. What the difference, the key difference is basically into the safety profile. So lysocell therapy provides a higher or a bigger margin of safety compared to axi-cell therapy. Percentage of CRS therapy was much lower with lysocell therapy compared to axi-cell therapy. This is probably because of the co-stimulatory molecule. So axi-cell, the co-stimulatory molecule in axi-cell is CD28. CD28 is a rapidly proliferating co-stimulatory molecule, meaning that when you inject axi-cell therapy, the cell divides rapidly and attack the tumor. When it attacks the tumor, the risk of CRS and the risk of ICANS is higher. Lysocell therapy, on the other hand, relies on the 4-1BB. 4-1BB is a provides the slow proliferation, but sort of the preservation and persistence of CAR T cell therapy in the patient's body. And this is probably why we tend to see higher CRS grades and higher ICANS grade with axi-cell therapy compared to lysocell therapy. Again, the risk of other side effects such as the cytopenia, the neutropenic fever, the infections was lower with lysocell therapy compared to axi-cell therapy. So the conclusion of this, when it comes to efficacy, there is really no difference whether you're using lysocell or whether you're using axi-cell therapy. Maybe when it comes to safety, lysocell has a more favorable safety profile compared to axi-cell therapy, but the most important part of the patient's outcome is basically early referral and early therapy, early access to CAR T-cell therapies. This is basically another real-world evidence that looked into lysocell therapy and axi-cell therapy. Again, outcome is more or less similar and very between axi-cell and lysocell therapy. What about using CAR T-cell therapy in a third-line setting? This is an updated version of ZUMA-1 trial. And basically, ZUMA-1 was put as axi-cell therapy in a third-line setting for patients with diffuse large B-cell lymphomas. And patients received axi-cell therapy and were followed for extended period of time. And this is what we can see here. The lymphoma-related event for patients was around median of around 5.8 months. But the most important thing that we need to keep in mind that if the patients survive the initial part, the initial 6 or 12 months of therapy without a disease relapse, the disease will not relapse down the line. So you can see here a flattening of the curve, even with a very long follow-up, close to 70 months, patients still achieve cure. So following patients closely for the first 1 year will give a reassurance that probably these patients will not relapse down the line. So this is the 5 years lymphoma-free survival. As you can see, 60% of patients has a primary refractory disease. However, if the patient, and this is the most important part, if the patient achieved CR, they're probably going, and they did not relapse early in the disease, their CR probably gonna continue for a very long time. So the conclusion that the 5 years lymphoma-free survival showed a potential for cure for patients who receive axi-cell therapy for diffuse large B-cell lymphomas. And the CR at 12 months and at 24 months is very important and are predictive that those patients who achieve those two landmarks, probably their disease will not relapse in the future. So in King Faisal, we have done as well CAR T-cell therapies, close to 200 adult patients between diffuse large B-cell lymphoma and adult T-cell leukemia as well, and pediatric T-cell leukemias. So our guidelines, patients who don't get CAR T-cell, if they have myocardial infarction, they do have a poor performance pulmonary functions or uncontrolled infections, or they do have poor kidney functions. So this is the real world evidence that we published. If you look here, the number of publications at the time of the publication in last year, ASH, in a second line setting, around 19% of 19 patients received CAR T-cell therapies, and the CR rate was close to 60%. And in a third line setting, the CR rate was around 60% as well. If we look here to the progression-free survival, at 12 months, the progression-free survival was close to 56%, and an overall survival was close to 94%. By this, I conclude, and happy to answer any question.
Thank you, Dr. Fadl, for the excellent presentation and comprehensive presentation about real-world evidence for using CAR-T treatment in lymphoma. Now we will open the Q&A session, and kindly, if anyone has any question, can be posted in the Q&A box or in the chat box. Again, thank you very much, Dr. Fadl. I will start maybe with a question. Now, what to do with those who did not respond post-CAR-T as second line for refractory? I mean, if you have a refractory disease, primary refractory, and you inject him with the CAR-T, 30 days post-CAR-T, you assess the patient, there is no response or like persistent disease. Would you wait until like you assess him again after 1 month or 2 months, or would you give something to enhance the response?
Yeah, excellent questions, and we see it all the time. So here, really having the clinical context is very crucial. So let's say if you're dealing with a bulky disease, and that bulky disease, day 30, majority of this bulky disease is gone, and you're limited with a very limited number of disease. So I wouldn't rush and go to the second line setting. I will probably repeat the PET scan either in 30 days or in 60 days, day 60 or day 90. However, if you're dealing with a primary refractory disease or day 30 and the disease did not change, that's a different ballgame. The patient is primary refractory. The patient did not receive CAR-T cell therapy. In that setting, I would favor using bispecific if the patient has access to that. And it has been shown that CAR-T cell therapy does not affect the bispecific response. So whether the patients receive CAR-T cell therapy or did not receive CAR-T cell therapy, responses to bispecific glofitamab or epcoritamab is more or less the same. So in that setting, I would favor bispecific therapy.
Okay, thank you very much. Any studies about, now maintenance post-transplant and post-CAR-T therapy becoming something essential to reduce relapses and enhance responses to cellular therapies? Any studies about giving any maintenance type of treatment post Yescarta or post CAR-T for lymphoma?
So there has been an initial enthusiasm about giving PD-1 inhibitor, nivolumab or pembrolizumab, in order to augment CAR-T cell therapies. Unfortunately, this did not really translate into an improved outcome. So even in our center, initially, we used to give patients all the time nivolumab, pembrolizumab, trying to enhance the CAR-T cell, especially in patients who had, day 30, you see some disease activities. The patient is responding, but not the degree that you're looking for. Unfortunately, if the patient is going to relapse, they're going to relapse. There are other very limited trials that looked into instead of giving the whole CAR-T cell therapies, you divide the CAR-T cell therapy, give the initial dose, and in a couple of days give another dose, and it showed probably a higher response rate, but the number of patients was very limited, so we cannot really have a very long or generalized conclusion of this. There is another trial that looked into using different CAR-T cell therapy. Let's say AXA cell therapy, you give lysocell therapy or vice versa. And those patients, there is a response, but again, very limited number of patients, very difficult to generalize, especially if we keep in context that CAR-T cell therapy is pretty expensive.
Yeah, and thank you very much. And in line with this, there is a comment by Dr. Afnan Suleiman in the chat box mentioning the AXA shows good response rate in diffuse large B-cell lymphoma, but in real-world practice, including their center, many patients relapse within 3 to 6 months after infusion. So, despite the initial efficacy, maintaining a durable response is still challenging. And also in our center, National Guard, this is what we see. Some patient, despite giving the CAR T, they still progress or relapse post CAR T. I think, at least in our center, these patients who are those who are late failure, very advanced disease, bulky disease. So, do you have any comment about this, Dr. Fadl?
Absolutely, absolutely. Like, when you're dealing with someone who's a primary refractory disease, if the patient's performance status is borderline and the disease is bulky, the chance of this patient surviving is very low. So catching patients early is very crucial, and giving CAR T cell therapy early is very crucial. I'm a big believer in bridging therapies, and it has been shown, although that many of the trials that has been published, there is a caveat to that, and of course, because of the nature of the disease. But I'm a big believer on bridging therapy, trying to manage this bulky disease and minimize the disease as much as possible prior to CAR T cell therapies. Radiation therapy has been shown that to be probably a little bit superior than just giving a mere chemotherapy if the patients can receive CAR T cell therapy. Sometimes if the disease is widespread, it will be very difficult to give radiation therapy. But if the disease in one area, giving radiation prior to CAR T cell therapy, a abscopal effect will improve the outcome. But again, despite all of this, there are patients who, you check all of these marks, and the patient is a low volume disease, excellent performance status. You give them radiation prior to CAR T, and you collect lymphocytes for CAR T cell. You give radiation, and then you give the CAR T cell therapy, and they still persist. That's unfortunate. But still, if we're looking to the other half of the empty part of the full part of the cup, there are patients who actually achieve a cure. So we're much better than the chemotherapy era, but we're definitely not in the where we want to be.
Talking about bridging therapy, now we know in the study that led to the approval of Axicel as the second line, they did not give bridging therapy. So you are supporting giving bridging therapy. Is there any scenarios that you will not give bridging therapy, or you will give bridging therapy to all patients? And is there any preference which type of bridging therapy you, based on your large experience at King Faisal Specialist Hospital, which bridging therapy you will propose for the attendees?
So when it comes, yes, you are absolutely right. Bridging therapy was not allowed on Zuma 7 trial except for steroid. Steroid can be given for patients. And we use a steroid in a setting of a bulky disease in patients who were afraid of developing ICANS or severe CRS. But you're absolutely right. Giving chemotherapy was not allowed in that trial. However, different. There is a lot of applications about bridging therapy, and it works. Giving bridging therapy, decreasing the tumor volume works for those patients. However, the real balance is you want to decrease the volume of the disease, but you don't want the patient to be very deconditioned. By the time the patient receives CAR T cell therapy, he's already like performance status of 4, and he will not tolerate CRS, and it may kill him, etc. So having this balance is very essential. What we use in our center, if the patient can receive radiation therapy, that will be the best. If the patient cannot receive radiation therapy, we tend to go with a low intensity RGM-OX, for example, in order to control the disease, rather than RE-SHAP, for example, because RE-SHAP can knock the patients down, and by the time you may see a response on a PET scan, but the patient performance status is very poor at the time of CAR T cell therapy. I don't know what's your experience, Dr. Zahrani, in your center.
Yeah, so if the patient is stable and the disease is not rapidly proliferating, we try to avoid bridging therapy. But if there is like advanced disease and bulky disease, we give chemotherapy, R-Remox or Bola R-Remox, and sometimes we introduce radiation therapy for some localized lesions, similar to the approach that you are doing in King Faisal. Now, regarding the use of steroid, there is like cohort 4, cohort 6, where they give steroid like as early as with the initial signs of CRS or even prophylaxis. And there is always debate about this giving steroid may affect the CAR T. And there are many centers they are using especially in US, using the steroid as prophylaxis for CRS. What is the practice at King Faisal?
If the patient is not, so we tend to use it if the patient is high risk of CRS, bulky disease, or in an area that we don't want the patient. Like for example, a patient of mine, and this is of course was excluded from Zuma 7 trial, but we know that CAR T cell therapy works in patients with CNS disease. So in that patients, with that specific patients, we give her steroid just because of the fact that we don't want her disease in the brain to get worse. But in a setting of bulky disease, we do use a steroid in patients with a high risk of developing CRS. But we try to stay away from using it for if the patient has a minimal disease because of the fear. Although the evidence shows that probably low dose steroid, يعني 0.5 or 1 milligram per kilogram will not affect the CAR T cell therapies. Usually CAR T cell therapies يعني البulse steroid which tend to give in patients with CRS grade 4 or severe ICANS. Those patients, those pulse very high dose steroid is probably the one that affects the CAR T cell rather than يعني low dose. But still, if the patient is limited amount of disease, we wouldn't use steroid.
Okay, thank you very much. We have a question here. In case of primary refractory disease and patient referred for CAR T center, in the meanwhile, patient given salvage, and this is commonly seen, given salvage, and he shows response. Would you take him for autologous or CAR T?
This is a 1 million question. And to make it even difficult, what about patients who achieve CR? Yani patients, you
Mm.
give them bridging therapy and they achieve CR, and it's a tough disease. Mayo Clinic published a retrospective, very interesting retrospective, although yani, it has been criticized by many, which they looked into patients CAR T cell therapies, actually patients who achieved partial response, and those patients received eventually CAR T cell therapy or autologous stem cell transplant, and per their analysis retrospective, autologous stem cell transplant did perform better. But however, يعني the patient selections, the disease status is probably patients going for salvage. Those are low risk patients versus high risk patients going for CAR T cell therapy. Many things that you can يعني criticize this article on. My personal preference, if the patient is fit to receive CAR T cell therapy, primary refractory relapse within 12 months, I will give him CAR T cell regardless. If it works, it works. بالعكس يعني it will be even better for patients if he has a very limited amount of patients. But this is يعني a 1 million question to ask, and it's يعني it makes the tumor board very challenging. You will vote 10 different hematologists will give you like 10 different votes. But this is my own preference. What about
Yeah,
you,
I
Maxim?
agree with you. It's easier for us as CAR T center, but it's more difficult for those who are referring the cases because some centers or some physicians they think there is a like difficulty in referring or accepting cases, and the patient is sitting in front of them. So seeing this result from Mayo Clinic or other studies may be reassuring to them to give salvage treatment. However, the standard of care, we should follow it, refer patient immediately for CAR T, and all CAR T centers accept cases and can see cases within 1 week in our center and your center. we fast track seeing these patients because the hour will start to click from the seeing him until the infusion. It will make a difference the time. Thank you very much. Now, maybe the last question, in the elderly patient that you show from Zuma 7, yes, they have better median overall survival at 12 months. But when you see the curves at 4 years, both event-free survival and overall survival was almost close to those patients with the standard of care. So, what does that mean? Does it mean that there is like late deaths or late relapses? If they measure like the outcome at 4 years, maybe it is different.
So we'll wait for an update on this to have a final conclusion. But it does work. So CAR T cell therapy, it does work. The usual stratifying, for example, in autologous stem cell transplant, you stratify patients according. One of the parameter is the age. If the patient above a certain age, 65, 70, this patients automatically will say the patient is probably not going for autologous stem cell transplant. Provided you have other factors as well, probably I'm gonna go with whatever polatuzumab, bendamustine, rituximab, you name it, any therapies in patients who are not eligible for CAR T for a transplant. In a CAR T cell world, age the performance of age one double hit. So double hit typically usually they are chemo resistant. Whereas in CAR T cell therapies, actually double hit, they do respond to CAR T cell therapies a little bit lower than non-double hit, but the difference is not similar to the difference between chemotherapies, double hit and non-double hit. So CAR T cell therapy, the usual prognostication is very different with CAR T cell therapy. So age, if someone good performance status who fits and can receive CAR T cell therapy, I would certainly give him CAR T cell therapy. I wouldn't look to the age as the sole exclusion factor. I would look at it in the context of the patient's performance status. For example, personally, I've done a CAR T cell therapy to someone who's 72 years of age. But that 72 was very fit, performance status of zero, kidney function normal, liver function normal, and he achieved cure, alhamdulillah. Now 2 years post CAR T cell therapy, and he's in remission. So I wouldn't take just the age as an exclusion factor.
I agree with you, and this is our observation for those older people who are fit with no major comorbidities. It is our observation their tolerance is very good, and maybe if we compare them to younger age, it will not be big difference, especially regarding the toxicity. Okay, I don't see any more questions. Thank you, Dr. Fadl. Thank you very much. It was very nice presentation, comprehensive, and excellent discussion. And thank you very much. I'd like also to thank all attendees who attended this webinar, and also at the end, I will thank Saudi Society of Blood and Marrow Transplantation for organizing this webinar and for the sponsor, Gilead Kite. Have a good night. Thank you very much. مع السلامة.